who can speak on some subject on which they are very good into it. And that's the reason for the grand rounds. Today, I'm really very happy. We have invited Dr. Sharda Jain Madam. एज हीमोग्लोबिन 12 ग्राम होता है तो मैं 12 बातें ही बताऊंगी, छोटी छोटी बताती हूँ उनके बारे में, बिकॉज आई एम रियली अ पैशनेट एडमायरर and what not. So she is the most passionate crusader for the women's health. Number one. Number two, 52 years ka experience hai, clinical. And that's contribution is not into the consulting room, it is beyond. And most important point is a landmark contribution hai unke, that is she was the person who started the anti-female feticide movement, one of the first in the country. That's a really a great thing. Then her another point is no home delivery campaign. That's another laid the groundwork for the Janani Suraksha Yojana and Asha scheme. So I'm really proud that a person with us is who has worked for this campaign earlier, and so that we have the Janani Suraksha Yojana and Asha scheme with us. Now she is developing the National Rape Victim Examination Manual, kit and film with IMA, UNICEF and MOCOW, now used across the neighboring countries. So it's a really proud moment for us. Now, 2 decades of teacher in a PGI Chandigarh Lady Hardik Medical College, that's another point. But she is the founder of Delhi Gynecologist Forum and North India Gynecologist Forum. It's a really, I think, not an achievement, but it was a need for the North Indian doctors to having their own association as well as forum for them. And she has received Lifetime Achievement Awards by the Lady Hardik Medical. This is not so important, but important for others, that this has, we look now as we are seeing every day the Padma Shri and Padma Bhushan, the way we get the goosebumps by seeing it. So that's very important for us to a person like Sharda Jain Madam is another in that category I come. And then she is there to, as a clinician, trying to change the many national policy. Work is inspiration to every gynecologist who believe that their role extends beyond the clinic, consulting room, and operation theatre. So, welcome, madam, to the grand round. And this topic of yours is really very important for all of us. Severe anemia kills the mother, and severe anemia kills the baby.
Yes, I'm passionate for Viksit Bharat, and I'm going to talk on a topic today. When I joined the medical college, the problem of anemia was great, and not that in the last 79 years we have made a major breakthrough. So this is my topic.
Yes, ma'am. You can make it in a full screen.
Now, you can see that, one message which I wish to give it to everybody, that severe anemia is the mother and severe anemia is the baby. This problem is 100% preventable. And this is what the aim of this particular presentation is, that if the two messages go across, that it is not the mild anemia which kills. It is the severe anemia only which kills the mother and the baby. And a moderate anemia, when it combines with any of the obstetrical problems, again, is the killer. I always call it the DIC, death is coming. So whatever I'm going to talk is everything is evidence-based on severe anemia, both by the government of India and the latest FIGO guidelines which are there, which have been released on the 5th of October, 2025. Now, as you can see here, that India adds 23 million births every year. Practically every second a baby is born. This particular slide is very, very dear to me. I've been using it for the last 2 decades. You can see here that it again highlights that it's severe anemia kills the mother, kills the baby in the utero, and is also responsible for neonatal deaths. And it is a mild and moderate anemia which affects the child development, the school performance in terms of academic grades, and the work performance. Whenever a child is doing badly, it's anemia behind it because the brain utilizes 20% of oxygen. And if that's not there, then you'll find that that kind of 100% grades empowerment is not there. At this talk of mine, I just wish to give 2 messages. Again, I'm repeating with fourth time, it is the severe anemia which kills the mother and the baby. And the second major thing which I wish to tell you is the hemoglobin of the mother throughout the pregnancy and at the time of delivery decides the IQ of the baby. And that is why we wish to aim that when she enters the pregnancy, her hemoglobin should be 12. In the mid-pregnancy, in spite of the government may say it is 11, we say it should be 12, and at the time of delivery also, it should be 12 grams. There is no confusion as far as the definition of anemia is concerned, whether it's the government of India, whether it's the WHO, whether it's a FIGO, it's the same. 11 gram percent is the cutoff, and in all trimesters you take. Non-pregnant, you all know that the cutoff is 12 gram percent, and because in pregnancy the cutoff is 11 gram percent, so severe anemia is anything which is less than 7. While in a non-pregnant state, the severe anemia is classified whenever it is less than 8. It is also there as a functional iron in the muscles, and it is there as a transport iron in the form of a hemoglobin. So there is a stage when everything is perfect. You can see the storage iron is full, the transport and the functional iron is absolutely great. At that time, the ferritin levels are 60, around 60. And you can find that the hemoglobin of the girls are more than 12 gram percent. Then a stage comes, when all the stores are gone. At that time, the ferritin levels are 30 microgram. Now, FIGO says it is 30. Earlier, we used to say it is 15, but I think FIGO is correct. Whenever you find the ferritin levels are less than 30, it means the storage iron has become 0. At that time, the functional iron in the muscles may be all right, and the transport, your hemoglobin, is still more than 12 gram percent. And this is the gray area. This is called iron deficiency, and we did not recognize this earlier. And 50% bad thing has been done by this particular thing. That, you do not realize your stores are all gone, and your hemoglobin is 12 gram, more than 12 gram percent, and you're happy. But then the stage comes that you don't act, your ferritin level further drops. It drops to less than 15, and still your hemoglobin is more than 12 gram percent. And then comes a stage, then still you have not worked for it. Your hemoglobin also drops, and your ferritin levels is also less than 12 gram percent. It will be 12, then tomorrow it will be 11, then 10, 9, and 10. So this is what is happening. So you can see here there are two distinct terms. These distinct terms have been clarified for the first time and emphasized by in a FIGO newer guidelines. There is something like iron deficiency, where your hemoglobin is more than 12, but the stores are gone. And there's iron deficiency anemia. The stores are also gone, and your hemoglobin level is also less than 12. And whenever the muscle hemoglobin, muscle iron comes down, this is the time that you start feeling fatigued. So when you start feeling fatigued, you find that your stores are already gone, but your muscle iron is also less. And that is something, you need to get up. So by the time the anemia is diagnosed, the stores are all exhausted, and that's not a happy situation. Now, this is the pie graph of maternal mortality given by the government of India in 2024. And you can see here, the direct cause of anemia has been only 8%, but the indirect causes have been close to almost 30%. So I again repeat for the 5th time that the severe anemia kills the mother and the baby. But it's the moderate anemia, whenever it is combined with any obstetric complications, the death is coming. And at present, the severe anemia rate is around 2% in 2024, and it is a red flag sign. Again, emphasizing the same thing when I was a medical student, joined medical college. Again, people used to say it in Southeast Asia, the cause of anemia, direct, indirect, is 30 to 40%. It was 40% that time and 30% now. Now, so the definition is very clear. FIGO and the Government of India guidelines are the same. Severe anemia is less than 7 gram percent. Very severe is less than 4 gram percent. And this particular cutoffs are very, very high risk for the mother's death as well as for intrauterine fetal death. Now, maternal risk with severe anemia increases maternal mortality 5-fold because of the heart failure, because of the sepsis, and because anoxic uterine vasculature are inherent risk for
atonic peak pH. So by anemia itself, also it causes peak pH. Fetal risk because of uteroplacental hypoxia, you can find 20 to 30% if hemoglobin drops 7 or less than 7 gram percent. So the government of India target is that we must have the severe anemia should become 0 by 2030. And this is one of the aims of Anemia Mukt Bharat. The lot of emphasis has been rescheduled again in 2023 and 24, again, that severe anemia should be eliminated and there will not be any maternal death as a result of that. So any pregnant woman with less than 7 gram hemoglobin, if she is symptomatic, the symptoms of failure will be dyspnea, angina, altered sensorium. And in obstetric emergency, this patient, according to the government of India, need to be admitted in hospital. There is no OPD treatment for this, whether she goes to the ICU or HDU, depending upon what is available to you. And this brings to a good point that anemia does not happen overnight. It is 100% preventable in the antenatal period. Only you have to pick it up. So the universal screening has been emphasized by both the government of India. It is re-emphasized by FIGO. The FIGO says that it should be done at the initial part in the first trimester. Again, it should be repeated around 24 to 28 weeks and at 36 weeks. What all need to be done? CBC and peripheral blood smear, we have been always giving it importance. In India, there has been also government is trying to see that thalassemia need to be ruled out by getting an HPLC done. It is screening is mandatory as far as Delhi is concerned. Some other areas where you can find sickle cell and thalassemia is common, but it is still not universal. Niti Aayog has been trying to that it becomes universal. Now, the ferritin has been emphasized for the first time by FIGO, and I think, I have already told you what is the basis behind it. Now, whenever severe anemia is expected, whenever there is a history of previous anemia, whenever patient is having a multiple pregnancy, or there is a short inter-pregnancy interval, less than 12 months, or she is a girl who has a teenage pregnancy. Fortunately, now in India, the teenage pregnancy contributes only 7%. Now, prophylactic iron, again, have been emphasized by the government of India and FIGO. In spite of your hemoglobin is 12 gram percent, the pregnant woman requires prophylactic iron. That is 60 milligram elemental iron plus 500 microgram of folic acid for 180 days past 12 weeks of pregnancy. Now, FIGO has this time emphasized in case you find there is a GIT intolerance, she can have intermittent iron, which can be given on a weekly basis. 120 milligram iron with 2.8 milligram of folic acid can be given every Sunday. We have not tried it. I think, in various parts of the country, this should be tried again, whether a person who has a hemoglobin of more than 12 gram percent once a week iron in this particular dosage, and the formulation is as good as daily dosage. Now, FIGO emphasized this thing for the first time and made it very, very clear that IV iron for prevention must be used in mid-trimester if the hemoglobin is less than 10 gram percent at 20 to 28 weeks of pregnancy. And the single dose of IV iron, that is ferric carboxymaltose 1000 milligram, to be used along with the supportive treatment and the diet to prevent progression to the severe anemia. I think this particular part is very, very essential that all gynecologists should work on a moderate anemia, which they fail to do it. As for the Government of India guidelines are concerned, I think IV iron for prevention, it has in 23-24, they have re-emphasized that a woman with a hemoglobin of 10 gram percent or less than 10 gram percent, if she is close to term, that is if she reports in third trimester, or there is a failure of increase in hemoglobin by 1 gram in 3 to 4 weeks after giving 2 tablets of iron folic acid. आपने 2 tablets of iron folic acid की दी, उसके 3 हफ्ते के बाद आप देखो 1 gram नहीं बढ़ा है, तो this is the patient who requires IV iron. Do not continue with oral iron. And the dose is single dose of ferric carboxymaltose. If you use it, 1000 milligram, it will definitely prevent the progression to severe anemia. Now, as far as anti-helminthic treatment is concerned, भारत की मिट्टी में तो कीड़े हैं. So WHO and the both government of India says single dose of albendazole should be used, 400 milligram after first trimester. And not only endemic areas, I think whole of the country is endemic as far as the hookworm infestation is concerned. Sickle cell, I have already emphasized to you. It is already mandatory in Delhi, and Niti Aayog is trying to see that it is done across the country. I'm told that the budget which is involved in screening such patients will be amounting to 30% of the total health budget, and that is why the government is slow on this. Now, whenever you find there is a severe anemia with normal iron studies, here you require to consult hematologist. I think this cannot be avoided. Now, coming to immediate assessment and triaging as far as anemia is concerned. Whenever you find that the patient is admitted with severe anemia, you need to see ABC, airway, breathing, and circulation. But in addition, you must see to it that the fetal heart is checked by Doppler. You also listen, and you make the patient also listen to the fetal heart sound. Red flag for the decompensations are that, you find the respiratory rate of more than 30, or the heart rate is more than 120. There is a gallop rhythm. And this patient requires ICU admission. And if you delay it, you can find that, the death is not far away. Investigations according to the FIGO, within 30 minutes, all these investigations need to be done. And goes without saying that the patient is in a hospital where all these facilities are available. Now, Government of India says that need for admission is there whenever the hemoglobin is 7 or less than 7 gram %, cross-match 2 units, and give her a packed cell red transfusion immediately. Transfusion trigger is if the hemoglobin is less than 5 gram %, or she's acutely bleeding, or there's an evidence of shock and cardiac compromise, you need to give a transfusion. IV iron akele se kaam nahi chalega. Now, when IV iron is needed, whenever you find that hemoglobin is less than 7 gram %, but that she does not have features of cardiac compromise or shock. Now, as far as the treatment is concerned, you need, whenever these patients are admitted with symptoms, they require stabilization, and the packed cell blood transfusion need to be given. This the Government of India highlights. Rate of 1 unit of blood transfusion should be given over a period of 2 to 4 hours. Then you reassess by auscultating the breath sounds for basal crepitations. Whenever you have given half unit of blood has been given to avoid transfusion-related circulatory overload. So आपने बहुत जल्दी भी नहीं करनी, but at the same time ये नहीं कि आपका एक transfusion है वो 24 घंटे तक चलता जा रहा है. You need to cover it up in 2 to 4 hours time. The target again is for a delivery. You need to have a hemoglobin of 7 gram %, and for cesarean section you need to have more than 8 gram %. These are the Government of India guidelines. Do not give prophylactic diuretics except if frank pulmonary edema is there, because if you give diuretic, it is going to worsen the hypovolemia. You need to give furosemide only if the basal creps are there, or you find a very easily diagnosed SpO2 when it drops around 90 or 92. Again, it alerts that, it is a time to give diuretic to her. That is furosemide 20 milligram IV slowly. IV iron protocol, which iron need to be given? Again, it has been, for the first time, has been made very crystal clear in a FIGO's guideline. According to the FIGO's guideline, they have made it very clear that, you have to give IV iron without decompensation. Otherwise, or patient refuses, many patients because of religious reason or डर के मारे क्या है कि they said नहीं doctor blood transfusion तो हमें नहीं लेना, or wants to defer blood transfusion for one reason or the other. Again, you need to take due signatures for the same. Now, FIGO says that the first line of IV iron treatment is ferric carboxymaltose. The total days, all of you know about it. The weight in kg multiplied by deficit, hemoglobin deficit multiplied by 2.4 plus 500. Maximum single dose is 1500 milligram. Now, As far as FIGO is concerned, again, the time has been emphasized very much. 500 milligram has to be transfused over a period of 6 minutes and the 1000 milligram over a period of 15 minutes. And if you're giving a single dose of 1500, you should not take more time of 20 to 25 minutes. If you delay it, the chances of of the reaction is more. The alternative suggested by FIGO is iron isomaltose, 1000 milligram, again to be infused over a period of 20 minutes. Now, as for the safety is concerned, IV iron is preferred in the 3rd trimester because you do not have hemoglobin rise time, which takes almost 7 to 8 weeks. And if she's come in 3rd trimester, you have to give IV iron. There is no increased fetal risk, and FIGO gives a grade A evidence for its support. Anaphylaxis risk, हमारे gynecologist यही करके मर जाते, reaction होता. The reaction is 0.002%. It is less than the penicillin injections. And always what one has to keep the emergency tray ready, which has adrenaline, it has hydrocortisone and antihistaminics. But the treatment for anaphylaxis is adrenaline. The ampule has 2 cc, 1 cc you take it, give her in a deltoid region, not in subcutaneously, because subcutaneously it will take little more time. And in pregnancy, I think, it is good to give 1 cc in deltoid region. If you have to repeat it, again, you can repeat it in 15 minutes time. Now, FIGO suggests long monitoring after IV iron. It suggests for 4 hours. Once you have given the IV iron, every 15 minutes it has to be done, and the patient should have to be kept in the hospital for 4 hours. Now, what are we doing? We are doing only that we give a very close monitoring during the time when IV iron is being given. Every 5 minutes, the patient is monitored during those 15 minutes when the 1000 milligram of ferric carboxymaltose is being given. And we make her wait for 1 hour in the clinic. And always do not touch the patient unless you have taken an emergency tray is ready and the consent is taken both from the patient as well as from the husband. As for the management of cardiac failure or pulmonary edema, I think it's a topic by itself. But we all know that the first line treatment is furosemide, 20 to 40 milligram. IV you need to give, and you have to give an oxygen supplementation to raise the SpO2 to 94 to 95%. We have to restrict the fluid markedly, intravenous fluid, which is to be around 70 to 80 milliliter per hour. The second line of treatment is nitroglycerin infusion. Again, it has to be given in an ICU setting. If a patient, you find it is a refractory, you have to use non-invasive ventilation, which is the trend these days, not to put these patients on invasive ventilation. This reduces the preload and improves breathing significantly. Avoid digoxin in pregnancy, and you can use dobutamine, again, in an ICU setting. It has to be done under the supervision of cardiologist. Coming to delivery and the fetal consideration. Onset of labor increases maternal mortality 3 times. If you find that if the hemoglobin is more than, around in moderate anemia or the mild anemia, the mortality in severe anemia becomes 3 times more. Now, timing of delivery, if already intrauterine fetal death has occurred. Don't wait. Don't delay blood transfusion for more than 12 hours. Correct hemoglobin to more than 7 gram %, and then induce or augment. Coagulopathy risk will be very minimal at this time. When the fetus is alive, patient requires very close monitoring with NST every 6 hours. If you fail to do that, if the hemoglobin is less than 7 gram %, you will lose the baby. Mode of delivery preferred is vaginal because the cesarean section itself can increase the mortality up by 40%. Now, as for the active management of 3rd stage is concerned, we were told earlier that, oxytocin should be given by intramuscular route to avoid failure. But now it has been very clear that oxytocin 10 units should be given intravenously. It has an edge over the intramuscular route. Carbetocin also you have to give intravenously, slowly over the period of 1 minute. Though if you give intramuscular carbetocin, the effect is there of uterine contraction for almost 2 hours. It prevents PPH effectively. Avoid ergometrin if the hemoglobin is less than 7 grams per cent. Now, as for the postpartum and the follow-up is concerned, Government of India has become very, very clear, because it is this time, either labor or postpartum period, that the mother dies. FIGO mandates postpartum blood transfusion if the hemoglobin is less than 7 grams per cent or patient is symptomatic. Symptomatic means dizziness, tachycardia, or dyspnea. The Government of India emphasizes now that IV iron, if the hemoglobin is less than 8 grams per cent at discharge. Oral iron, FIGO says, can be given for 3 months, but the Government of India is very, very clear that iron folic acid should be given for 6 months. Give IV iron if at the time of delivery hemoglobin is less than 10 grams per cent. Hemoglobin testing is mandatory after delivery. FIGO emphasizes time and again. Now, lactation safety, IV iron is safe and no interruption for breastfeeding is required. Family planning counseling, before patient leaves the hospital, she should be very, very clear that she should not become pregnant for 2 years. Insert PPICD, again the Government of India guidelines are there. HB should be more than 9 grams per cent before you put up this postpartum IUCD. Now, as far as maternal death review are concerned, every severe anemia-related death, maternal or fetal, must be audited per Government of India format to understand the cause, so for future prevention and delay. The corrective action for facilities is also very, very important. Now, coming to the almost last slide, the quick reference for doctors. Whenever you find hemoglobin level is less than 7 grams per cent, the patient is symptomatic, patient requires admission in the ICU or HDU and 2 units of packed cell blood transfusion. It should be done within an hour. If hemoglobin is less than 7 grams per cent and she has a cardiac failure, you definitely need to use a diuresis, non-invasive ventilation, and then transfuse her for hours after stabilization. If hemoglobin is less than 7 grams per cent and the live fetus is there, then give her antepartum steroids if the gestation is less than 34 weeks and she requires round-the-clock anesthesia coverage. IV iron, that is 1,000 to 1,500 milligrams, single dose can be given if you find that the hemoglobin is less than 7 grams per cent, or if you find she's symptomatic, you need to give a blood to her before IV iron. So you see this particular animal, you have to act that fast. Then it becomes life savior for mother and baby. As far as moderate anemia is concerned, 3rd trimester, if she comes to you, hemoglobin of less than 10 grams per cent, then in that particular case, you have to give her IV iron. You don't have to question yourself that isko oral iron dene ki zarurat hai. Mid trimester में आप 2 tablets of IFA दीजिए. 3 weeks के अंदर hemoglobin rise अगर 1 gram नहीं होता, again you have to give her IV iron to this patient. And postpartum में it is mandatory if the hemoglobin is less than 9 or 10 grams per cent, it is good to give them IV iron. There is a surplus of IV iron as far as the government stores are concerned. There is no shortage. Side effects, gynecologists need not cover because only 40% of gynecologists are using IV iron. The side effects in terms of anaphylaxis is 0.002%, which is less than the penicillin. Emergency tray, you have to keep it ready where the adrenaline is there and which is not expiry date. Consent for before IV iron, you have to take it from the patient and the relative, and you counsel her in case if the reaction happens, the observation will be there almost for 4 hours after the anaphylaxis. As far as the risks are concerned, you already know about there is a risk to the mother. And I think, if you are a little more energetic, there will not be any death because of severe anemia. And for prevention of PPH, you have to also take active action. For baby, you will find a preterm labor will be prevented. It will support the growth of the baby, and the stillbirth and neonatal, the stillbirth also will be markedly decreased. Neonatal anemia, I will always say that, delayed cord clamping should be there, because then only the maternal blood can be transferred to the baby. It is prior to delivery, it is 70 per kg, but if you do a delayed cord traction, it becomes 100 milliliter per kg if you do a delayed cord traction. So thank you very much. We want to tell you that hemoglobin is 50% across all girls and women in this country. The National Family Health Survey says even the doctors have hemoglobin of 50% have anemia. And as for the developed countries are concerned, the incidence of anemia is, I'm talking of less than 12 gram percent, is 5%. And in Viksit Bharat, we wish to have the incidence of anemia to be to 5%. And I feel, आप एनीमिया ठीक कर लोगे ना, एनीमिया खत्म कर दोगे तो आधा विकसित भारत की प्रॉब्लम खत्म हो जाएगी. So thank you very much. This is what I need to tell you, and I'm